your pelvis is too small, the baby is too big, it's too great of pain, you just can't do it. The word obstetrician means surgeon. How many babies have you delivered? Oh, I've delivered thousands of babies. Okay, you ask a midwife, how many babies have you delivered? I say, well, I delivered one, and that was my daughter. And I have assisted other women in delivering their babies. What's a birth center? What are you talking about? I have no clue. What's a midwife? All babies should be born in the hospital. They're tough. The women are tough. With all of this going against them, they were popping babies out like nothing. There's 30 women in labor in one room. She said they opened their legs, they need to suffer. I was like, okay, I'm gonna be nice to them. Look at that. Look at these women. Wow, it was an eye-opener. So I started the birth center in 1993, and it was for interesting reasons. I was not licensed as a midwife yet, and there were no schools that were open anymore, and so it was out of necessity so that I could get my license. So I wrote a curriculum, I went to a school, I asked them to consider doing the program. They said yes, but that they would need a clinical site. They said, so you have to open a birth center. So I said, okay. So I proceeded to open a birth center, much bigger job than I thought ever. And now I'm 70 and I'm getting ready to retire. So I do very few births now. But I have a wonderful staff and a lot of midwives that are in the community trained here. Okay, so this is our deluxe room. This is much bigger than the other two rooms. It has a full bathroom with a shower. It has a queen-size bed instead of a full, and it has the deep water experience. So the other two tubs are cleaned with Clorox bleach in between births, and we run the jets with the Clorox water. The manufacturer of this tub knows that we cannot clean it with Clorox, it would destroy it. So the company makes a liner that fits over like a fitted sheet and covers all the touchable surfaces. After the birth, we pump the water out and we take the liner off and throw it away. So everybody gets their own individual liner. This tub is very comfortable. The floor is blown up so it's soft on mom's feet or her knees. She can use this as a back cushion, as a seat. She can squat, she can do hands and knees. And no matter how tall or big mom is, she can lean on the sides of this tub and the water will not come out. This is our smallest birth suite. This is the seaside room. It has a jacuzzi tub, and mom can labor and or deliver in the tub. Dad can sit here with his legs in the water. He can sit back here with his legs around mom. Someone can stand there.
Designed for the birth center?
Yes, I designed the whole birth center. Yeah. And I put the spigot up high, and I put the controls over so that if Dad wanted to get into the tub with mom, he wouldn't have this in his back.
Yeah.
So this is the Tuscan room. The Tuscan room is our medium-sized room. Yeah. It has the same bathroom and the same tub. So when I do a tour, so I do about 3 or 4 tours a week where people that are interested in the birth center, they come. So I walk them around the birth center and I show them, and I do a demonstration of the rope. Mm-hmm. So talking about how squatting is very beneficial in labor, and being upright helps move the baby down and make the labor go faster. So, but most American women don't squat. Unless you're a yoga or an athlete person, most of us don't squat. So mom gets a contraction, she goes down into a full squat, and then when the contraction is over, she uses the rope and the wall to come up. Now, what if this room is not available? What if we're having a home birth? What did I do before the rope? So I've only had the rope for 19 years. Okay. So we do doorknob squats. Doorknob squats are straight arms, flat feet. get a contraction, go down into a full squat, and then use the door to come up.
Can you tell me how the birth center work is organized? I mean, what does she have to do to come to the birth center and to be sure that she's treated well? And I mean, she has the whole package. How does it look?
So they usually find us on the internet, on our website, or they've been referred by another client. We don't really call them patients. Or they're a repeat. They've been here before.
Okay.
So if they've never been here, they come for a tour. So pretty much what I showed you in the same talk. But I also sit down with them for about 20 minutes, whether there's one couple or 5 couples, and I tell them everything that we offer, which is it's an extensive explanation. And we walk around. I let them ask me as many questions as they want. If they want to come to the birth center, and I've already explained that we only take care of low-risk healthy women, and that there's no pain-killing medications here.
You don't have anything?
Nothing.
Nothing?
Nothing.
No gas?
Nothing.
Okay,
Yeah.
just water.
The water and being able to move around, so we show them the pictures so that they can see. They're not confined to a bed, and they can pick the position that feels good for them or makes them feel powerful. So then I give them a document, and I show them, to fill out their contact information and their insurance information. And then they email it back to us after they've talked it over with, the couple has talked it over. And then my staff sends them a link to the history. They fill out the history on their computer. They email it back to us, and they come for their first appointment. So their first appointment, of course, is lots of paperwork. We do a risk assessment to go through all of the health concerns and weight and all of this and previous births. And then they have an appointment. Whether they've had labs or not, we would draw their labs here. Do a pap smear, cultures, we test their urine every visit, we get their weight, we do blood pressure, pulse, temperature every visit. We listen to the baby every visit, we measure their belly after 20 weeks. So we do a fundal height. And then we ask them a list of questions just to let us know that their well-being and the baby is good as far as movement. And then they're on the same schedule that they would be if they were seeing an obstetrician. So it's every 4 weeks in the beginning of the pregnancy. When they get to 28 weeks, it's every 2 weeks. When they get to 36 weeks, it's every week until they deliver. We do a 20-week anatomy scan, ultrasound. If they need ultrasounds before or after that, we do them, but only ones that are medically necessary. We have them take their childbirth education classes when they're about 33 to 34 weeks. The breastfeeding class and the newborn care class is an ongoing once-a-month class, so they can pick and choose whatever month they want to take that class. We give them all of our contact information so that if they go into labor in the night or on the weekend, they can reach the birth center or a midwife. So they call they talk to the midwife about what's going on. We discuss with them how to know when you're in labor. Then if they're having a birth center birth, they come here and the midwife checks them. If they're truly in labor, then they would stay for the duration. If they're having a home birth, the midwife goes to their home and checks them, and then she would stay for the duration. So this is our classroom. This is where we do all of our classes, our workshop, childbirth education, breastfeeding, and newborn care class. Okay, so we're gonna go this way. So these are babies that were born here the first 15 years. And I used to have another one here, and one here, and one in the kitchen. But when we redecorated the birth center, my staff said, "Oh, Debbie, this is old-fashioned. We shouldn't put them all back up." So So then this is our kitchen. So we have a refrigerator, a coffee maker, a blender, a hot water maker for tea, and a toaster oven. We have an extra bathroom here for checking mom's urine and her weight at every visit, just like they do at a doctor's office. We have a lending library. The library books are on out-of-hospital birth, birth centers, home birth, nutrition and exercise in pregnancy.
This one is really great.
I haven't read it yet, but I'm going to read it now. You spurred my enthusiasm. Yeah. We have a dining area here for parents and for the staff as well, and the laboring mom if she feels like she wants to come out here. We have a seating area here.
And afterwards, what do you do in postpartum?
So we put the baby on the mom's chest. We are encouraging bonding and breastfeeding. We respect that first hour, that knowing that, you know, it's real important that we don't fuss with either one of them too much. As long as they're both doing good, we'd leave them alone. Then when they're ready, we would check and see if they have any tears. We would, we've already delivered the placenta. We would suture if we need to stitch their bottom. We did do xylocaine for pain, for numbing that area. We would do the newborn exam, which is done on the mother's bed right next to her. We're doing the same exam they do in the hospital.
It's the pediatrician who's doing it, or the midwives?
The midwife.
The midwife.
The midwife is trained how to do the newborn exam. We're only required to do 3 procedures on the baby. The eye ointment, the vitamin K injection.
Oh, still eye ointment? Up here in the United States?
Mm-hmm. And the heel stick for the metabolic screening. But we educate our families about what all these things are for. And then if they don't want them, that's okay. They just sign a waiver as long as they know. We help the mom take a shower. We make sure that she has food and she eats a big meal. She's breastfed a couple of times. We go over the postpartum instructions on how to take care of mom and baby for the first few days. Yeah, after we talk about all the discharge and we get all the birth certificate information. So we would help them out to the car with the car seat and the baby, and then they're leaving here 4 to 6 hours after the birth. Okay. But mom and baby have both got to be stable. Mm-hmm. So then what we do that the hospital doesn't do is we come to their home 24 to 48 hours after the birth to check on mom and baby. We come again to their home between the 3rd and the 5th day to check on mom and baby. Then they come back here at 2 weeks, and they come back here at 6 weeks. So they get a minimum of 4 postpartum visits, to home, to office.
And then it's done. I mean, that's the whole package.
Yeah, okay. Right. Although we do have people that are still calling us that their baby is 6 months old, 18 months old, what is this, what is that, should I call the pediatrician, when should I wean, when do I start solids? So we still have people calling us, which is fine.
Yeah.
Yeah.
And you just make consultations, or it's just free?
We just free. Okay. It just give them, that information over the phone.
Sense of family already.
Yeah.
Yeah.
So this is my staff. So these are my 3 main midwives. And Miriam is backup if we, like I said, get swamped. We have birth assistants. Our students have graduated and they are now birth assistants. We have Liz as our Medicaid coordinator. Tanya is our administrator. And Ada collects the money, answers the phone, and makes the appointments, and can give people a lot of information and sets up the tours. Languages, all of my staff, most of my staff speak Spanish. Okay. Liz speaks Portuguese, and Mila speaks Russian and Ukrainian. So this is one of our prenatal rooms. Can I show her the room? Yes. Yeah. Okay. Hey, Mimi. This is our large prenatal room. This is where most of the visits would take place. It also is where we store the birthing stool. So the birthing stool is a supported squat, so mom doesn't have to hold herself up at all. She can just sit on the stool, which is very comfortable. We have another one of these that if somebody has having a home birth, if they request us to bring a stool, that way we never leave the birth center without a stool. We have a small store, so the store has teas and herbs and vitamins. It's more for convenience so that people don't have to stop at Whole Foods on the way home or a health food store. And then we go down this hall. Well, it's decorative and it's very unstable, but it is a Spanish birthing stool. And I'm hoping that those women were really, really tiny. Yeah, very tiny, because it has hand holes for when she's pushing. But yeah, they must have been tiny because, yeah, and because 3 legs, forget it.
Yeah.
So these rooms are all exam rooms like that one, except smaller in size, and all of them are full.
Okay.
This room is a consultation room. We also use it for a lactation consultant. So one of our midwives, Betty, is a lactation consultant. And then we have massage therapy. So our massage therapist, she specializes in prenatal massage. She's certified in infant massage and prenatal massage. There's a package, and that's $7,200. That's for all the prenatal care, the regular labs, the childbirth education classes, to pay for the birth assistant, the postpartum care, the newborn exam. Whether it's a home birth or a birth center, it's the same price. We also take all of the major insurance companies.
Okay.
South Florida is wonderful because it's very diverse. So we have white, African American, Asian, we have Native American, we have every religion, Muslim, Orthodox Jews, born again Christians, we have bikers, we have vegans, we have hippies, we have average Americans, so we get everybody. So that's what's really great about it. Like over the years, we've had 3,000 here.
3,000
in 30 years.
In 30 years.
And about 2,000 in home births in 30 years. Month to month varies drastically sometimes. Right now things are a little quiet, so maybe 6 births a month, but usually we're at 14 to 16 a month. That's me.
Oh, really? Wow.
That's 39 years ago. It's in upstate New York,
So
out in the country. A lot of my friends in that area where we lived had home births. And so I started reading books about it because there was no internet back then and nobody had computers. So I just started reading books about it and I was fascinated. And then I actually went to a couple of home births before as a coach. Yeah, there was no doulas back then. You were just, someone coaching.
I know the difference, but I wanted to ask you, so that you as a midwife, as the owner of birth center, is it the oldest birth center in Florida?
Second.
The second oldest. Okay. Tell me the difference, or for the people who are going to watch us later on, the difference between the midwifery model and obstetric model.
The word obstetrician means surgeon.
Yeah, right.
So if you are high risk and you don't have faith in the process of birth or your body, you belong in a hospital. If you are low risk and healthy and you do have faith in the process of birth and your body, and you want to have an unmedicated birth, that should be available to you. Mm-hmm. So obstetricians usually see between 40 and 50 patients a day. They can't spend a lot of time with you. They can't get to know you. you come to their office, you sit in the waiting room for an hour or 2 hours. Now you go into the exam room and maybe you're wearing a gown for 20 minutes. It's cold. The nurse comes in and she gets your weight, she checks your urine, she does your vitals. Now another 20 minutes goes by and now the doctor comes in. He listens to the baby, maybe he measures your belly, he might ask you a few questions, and as he's backing out the door, he's asking you, do you have any questions? The visits are very short. Oftentimes if you ask too many questions, they get annoyed. So it's the opposite here. We respect the definition of an appointment. My midwives are seeing 5 to 6 patients a day. They allow for 30 minutes to 45 minutes for every visit. And the midwife does all of the care. So there's no waiting, there's a connection that is made between the midwife and the client. We get to know them, we get to know what is it that they want. You know, do they really, really want a water birth? They really, really don't want their mother-in-law there. They have very specific ideas about, and so we chart everything. What room do they want? So we're trying to give them what they want. Well, you know, just the mindset of a doctor. You know, they're given minimal nutritional education, if any, which that's going to secure a safe pregnancy when you really emphasize the nutrition and how important it is. And the doctor is seeing a lot of patients. He doesn't really get to know the woman. And then even at the birth, he's only coming in the room a couple of times or for when the woman is pushing. And he wants to get out of the room and go to the next room for the next patient. So they're a little bit in a hurry. Their feeling is that they're delivering the baby.
Yeah.
That the mom is just a vessel. She's not participating, and all the things that they do as far as the tight belly bands and the IV in one arm, the blood pressure cuff on the other arm, in the bed, not being able to move, and this is uncomfortable. Hospitals are scary places. You've put me in a hospital gown of somebody that, you know, like I was sick. You're treating me like a sick person. So it's not like you're doing anything. The doctor, how many babies have you delivered? Oh, I've delivered thousands of babies. Okay, you ask a midwife, how many babies have you delivered? I say, well, I delivered 1, and that was my daughter. And I have assisted other women in delivering their babies, over 680. So there's a difference in the mentality.
I asked this question, Michel Oden, by the way, in Amsterdam in 2018, was it? And his thought about this is that there are too many male obstetricians in the profession, and this is the field where women should take care of women.
And I hear you. I hear you. And I agree to a certain point.
Yeah.
But the female obstetricians that went through school, the males made it so hard for them to be there that they had to put on this exterior of, I can be tough just like you. I can, you know, and so some of them come out and they're just like the men. What am I going to a female for if she's gonna be harsh with me and not answer my questions and do the God thing?
Yeah.
You know, what's the point? So finding a female obstetrician that is gonna make you part of the team.
But it's hard to understand because the women are going to be mothers, or they are mothers themselves who was through this process.
But they didn't.
Oh,
I was working with an obstetrician years ago that she was my backup. I was so excited to have a female obstetrician because my mom's like that. But she was a little on the harsh side. And when she told the doctor, she was pregnant, her colleague, he said, "When do you want to schedule your C-section?" She said, "I don't want a C-section. I want to have a vaginal birth." And he said, "Doctors don't do vaginal births. They do C-sections. So you can schedule your office around it, your life, your practice." And so she tried to have a vaginal birth in the hospital with no support. She ended up with a C-section. Her next birth, she went to a licensed midwife and had a VBAC at home.
wow, yeah.
Yes.
Nice story.
So, yeah, the doctors, that's what they do.
But do they change their attitude? Like after the home birth she had, she came back to the hospital as an obstetrician.
Yes.
Did she change her practice after that? Do you think?
I don't know.
No, to tell you the truth, at the beginning it was not easy because I came from Venezuela in 2018 because I was a professor in university and I applied for a talent visa and they approved it. Then in Venezuela we don't have midwife.
Just doctors.
Yes, I had to review all the information about the babies because I have been an OB for 20 years. And then, take the baby, the pediatrician take the baby, and that's all. I look in the internet, all the birth centers, midwife, and I went to visit all of them, and the lady said, "No, you are a man, that is impossible for me because my patient look for a midwife because they don't want to see a man or a doctor. Maybe some of them for religious reasons. It's not easy to work with a man. And then it was very difficult for me to find a protector, very difficult.
We're started to talk about male and female in the profession. I would like to ask you about your midwife, one of the three ones, about Jorge. How do you call him?
Okay. That's an interesting story because he's been with us for 2 years. Okay. I'm really happy that he's here. So Florida has this unique situation that if you can prove that you were an obstetrician, male or female, from another country, and you're in Florida, you can take a 4-month course and you can become one of us. You are not an obstetrician, you're a licensed midwife. He can't do anything more than me. Okay. So Betty, my other midwife, she's the teacher for the 4-month program. So she called me one day and she said, "Debbie, I met the most amazing OB." I said, "Great, I would love to meet her." She said, "No, it's not a her, it's a him." I said, "There are no hims on my board," where we have all the, all the midwives' pictures. And she said, "Open your mind." And I said, "No." I said, "You and I are old-fashioned midwives. And the word midwife to us means women helping women." Yeah. And she said, "Yes." She said, "Just meet him." So I agreed, and I had my guard up. And I started sitting there and I'm talking to him, and he's so sweet and so soft and so reassuring. And I was like, okay.
But are you happy with everything, how it turned out?
Yes, it's really, really nice. Also, because of his background, when we get records from the other offices, there might be something in there that the mom forgot to tell us, and it's like important. And so he has found a couple of things like, oh no, this is a very scary condition or disease, and we need to, find out more about it, and and there's a possibility she can't deliver here because it's too high risk. But she never told us. Okay. Yeah.
But do you think it helps him more than distracts him? The background, the education of being...
No, I think it helps him.
It helps.
And what's so sweet about this whole thing is that he is so excited about doing this kind of birth, because he told me when I met him, he said he never imagined in a million years that he would ever think that this was okay. And that after he did his training, because he did his training with us, he was like, wow, this is so cool. And doing underwater births and home births. He's like, he loves it.
You know, I have an open mind. No? I know that we have to learn a lot of things, because this is a very different way that I used to do my things when I was a doctor in Venezuela. Well, we always think that the labor is going to be complicated. That's why we use IVs and all the machines, and you cannot eat because maybe if we have to use anesthesia, you have to have the stomach empty, and you start doing interventions that you don't need to do. Maybe it's more in our countries because everybody uses pitocin to conduce a labor, and then it's very common. But before I come here, I tried to change that because I was a professor. We don't have to use pitocin for all the patients, only the patients we needed.
Okay.
And you know, I tried to change things there as a professor. But now, I think that we have to learn a lot from the midwife. Usually the center in the hospital is the doctor.
Yeah.
But as a midwife, the center is the patient. It's very different. Because, you know, as a doctor, you are very square, you know. 2 hours for this, 2 hours for this. If the thing doesn't work, C-section. And, you know, here you learn you don't have a pattern. Each patient has their own pattern. The doctor thinks that we are like a crazy people, hippies, and we don't know exactly what to do. But, you know, I was surprised. You know, when I start to share with all the people, they are very prepared. They know what to do. And usually they know more things about positions and time that we know, because we usually, you know, I told you, we are very square. And maybe we don't give the time to the process goes naturally, you know. I think we have to learn a lot from the midwife. I have learned a lot from the midwives too.
I did some of my training in Jamaica. Part of my schooling situation back then was we did 2 trips to Jamaica, to one of the busiest hospitals in the Caribbean, in Kingston, Jamaica, and in Montego Bay. And wow, it was an eye-opener. The hospital was extremely busy. They weren't allowed to have their husbands or any support person on the floor with them. There was usually no records, no labs. The age range was from 13 to 46. There was no childbirth education. But what they did have was they had a really strong breastfeeding campaign, which I was impressed. The nurses and the midwives were mean to the women. There were no drugs, there was no food, there was no water. They did unbelievably well. They were such troopers, you know. They had babies under, and we're talking of poverty, super poor area. And with all of this going against them, they were popping babies out like nothing. We were running from bed to bed. We were exhausted. And I said to the midwife there, I said, how do you do this when we're not here? She says, some of them birth by themselves because I can only be with one woman at a time. And like I said, they did, it really brought back my faith in women, that under horrible circumstances, they have babies.
Why? What is so different with their culture so that they do it?
They're tough. If first of all, if you're born in Jamaica, they have nothing to save you. So if we had a baby that was in trouble, which was rare, they have nothing to save that baby. Because the hospital, especially back then, I don't know what it is like now, but 30 years ago, it was ridiculous. The oxygen tank was this huge, nasty, heavy tank that was at one part of the building, and we had to roll it to get it to the mom. I never saw anybody open it or use it, ever, the whole time I was there. And I was there for 2.5 weeks. And I saw one C-section. They had very few C-sections. The women are tough. Their culture is you're going to go into the hospital and you're going to give birth, you know. You're going to have a baby. It's just like, this is human nature. And I said to the midwives, I said to the nurses and the midwives there, I said, I don't understand why you were so harsh with the women. And she said, and she's gazing over the room, there's 30 women in labor in one room. She says, they opened their, first she said, they're not married. And I said, okay, I still don't understand. She said, they opened their legs, they need to suffer. I was like, okay, I'm going to be nice to them. So when I walked up to each bed that I was with a woman, I would introduce myself and I would breathe with her, I would hold her hand. Some of them would wrap their arm around my waist because you in Jamaica, you deliver from the side. Mm-hmm. And I got yelled at a few times by the midwives. They were like, don't let them touch you, they're dirty. I said, yeah, how could they be dirty? You made everybody take a shower before they came in, which we had quite a few babies in the shower room because even if they were pushing, they made them take a shower. So with no soap, no hot water, no towels, there were no supplies. There were no supplies. They would give us one pair of gloves and they would say, okay, hold your hands. This is your only set of gloves for this birth. And no air conditioning. So the sweat is dripping out of the gloves and you're standing there because you don't want to touch anything because you only got one pair of gloves. And we brought, with us, when we came, we brought boxes and boxes of supplies because we knew that they would need supplies. Yeah. But that was a wide an eye opener as far as, look at that. Look at these women.
Yeah, but we don't want to put women under such conditions
No,
to have faith in them. So what American women or Western women
but it's that
missing?
It's the mindset.
Yeah.
The mindset in the United States is you can't do this without drugs. You can't do this without a hospital. You can't do it without a drug. You can't do it. Your pelvis is too small. The baby is too big. It's too great of pain. You just can't do it. And so that's the mindset. Florida is very conservative. Okay. So it's a point system. Of course, somebody who's a high risk, diabetic, heart condition, high blood pressure, no. But like say if somebody was very fluffy and overweight, so that would be a 1. And then maybe they had asthma, a mild asthma, that would be a 2. So now they've added up to 3. If they had some other mild condition, then we would have to have an obstetrician, which we work with 2 obstetricians in the community.
But the woman still can have birth here.
Yeah, as long as the doctor looks over her health records and it feels comfortable with her giving birth in an out-of-hospital setting, he can give us permission. Okay. Even if her points are 3 or above. We're not allowed to do breech or twins here. Now we have had a few undiagnosed breech deliveries over the years. We even had a surprise set of twins about 17 years ago.
What happens when something goes wrong? This is the main question people ask about birth centers and midwives.
Okay. Because of the kind of women that we take care of, I call them the cream of the crop. Oh. So because of the kind of women we take care of, these are healthy, low-risk women who are committed. They want to have an out-of-hospital birth. So the ladies that we take care of, we don't see a lot of problems. Also, we are trained how to handle certain complications. So for instance, we have oxygen for mother or baby who should ever need it. We have the same sterile disposable tubing they have in the hospital for doing deep suctioning on the baby if the baby needs it. Mm-hmm. If mom bleeds more than we're allowed to see, we have an injection of a drug to stop the bleeding, same drug they use in the hospital. And if the baby is born and does not have a heart rate or is not breathing, everybody in their birth team is neonatal resuscitation trained. So that's a specialized CPR training to help that baby initiate that first breath or that first heartbeat. And our laws and rules, they're very specific. You can take care of this woman, but you can't take care of that woman. If this happens during the prenatal care, you need to refer to a physician or you need to consult with a physician. During the labor, if this happens, you call rescue. If this happens, you consult. If this happens, you would give her an injection to stop the bleeding. So everything is right there, and it's all in our training. So there's not even a whole lot of talking in the room when something starts to go the other way. There's a problem, we see the problem, the assistant or the student midwife is on it, and we're working together to solve the problem, and whether or not we need to transport to the hospital, we're all ready. And we're discussing it with the family as we're doing things because time is important.
So you call the rescue, you're not transporting her?
Only if it's an emergency transport. And we have very few emergency transports because of the kind of women we take care of. We have a larger non-emergency transport for biggest reason is failure to progress. So birth is very psychological. So if the woman wasn't completely on board with having an out-of-hospital birth, maybe it was her husband's idea, or maybe her friends had a home birth or a birth center birth, and she feels like she needs to do this, but she's not feeling it in her heart. And so now she's in this situation, and now the labor stalls, or the labor is going so long that now we're concerned about exhaustion. Or her mother-in-law is in the room, and here's this woman is naked, and her mother-in-law is standing at the end of the bed looking at her private parts, and it's, performance anxiety, or saying, certain family members saying things during the labor diminishes her confidence. Oh, we shouldn't still be here. Why is this taking so long? We should go to the hospital. This is not working. So all of these things play a huge factor in us having to transport to the hospital by car because it's not an emergency. And we get to the hospital, they either give her some Pitocin to make the labor go faster, or they give her some drugs to calm her down or let her rest. And then she normally has a vaginal birth. So we're using our backup doctors. Obviously, these doctors, they're working with a birth center and midwives, so they believe in vaginal birth. But we are going to the hospital, so we do need help. So getting to the hospital, and some of my moms, not many, but some of my moms knowing, oh no, I don't want that. Oh, I don't want that. And the doctor's like, why did you come here? Yeah. You needed my help. I'm here to help you. So, but they still have a vaginal birth. And I talked to them about this during the tour. We talked to them about it during their childbirth education classes, that you don't want to invite too many people to your birth. You don't want to invite people that are not 100% on board. These are all things that could cause us to have to leave.
You're doing this for 30 years right now. I mean, the 30-year anniversary this year, right? Do you see anything that has changed in the last 30 years?
I think that the doctors are getting a little bit more nervous about us because we're getting more popular. Okay. When I opened, I was the only birth center in Dade, Broward, and West Palm. Now there are 6 of us. Wow. And even though we used to be that we did less than 1% of all the births in Florida, we're doing more now. It's increasing. And there are more licensed midwives out there. There are more home births. And I think the doctors are getting uncomfortable. And it's just, I just don't get the threat. It's like all these people out there and all these high-risk women who need you or want drugs. there are plenty of all different kinds of women that should get what they want. And you should be supporting the midwives, because if they have to transport or transfer somebody out of care because we discover twins, you are going to get those people. And you've got a relationship with this midwife. I just don't get it. So I think that they're getting more nervous. Yeah.
That's a good sign.
It's not a good sign. It's a good. It's a good sign that we're becoming more normal.
Yeah.
The internet has done a tremendous amount for us, because people can go online and look it up.
That's how I found you.
Yeah. And so before, we didn't have anything like that. We had to advertise and go to baby fairs, and even then people would come up and they'd be like, what? What are you? What do you do? And now, I remember when I first opened, I could have walked out onto the street. And my building is here. It says birth center right on the thing, on the wall. And I could walk up to them and said, here, you know, we're a birth center. We have babies in this building. And they'd be like, what's a birth center? What are you talking about? And then even after I was here 10 years, the same thing. They don't know what a birth center is. They don't know we're there. And they walk by my building every day. Have no clue what's a midwife. But now, with the internet has made a huge difference.
If you had all the power or all the magic in the world to change the birth culture in America today, what would you do first?
What would I do? I would go into the medical schools, and I would retrain the doctors about what a midwife is, and that birth is a normal physiological process, and that you are here to support the midwives and the women who need you. And because you have to start somewhere. And if they're being trained, depending upon who's training them, some of them come out of medical school and they detest us. They feel like we are loose cannons and that we are harming people. And you can only feel that way if you truly believe that what you do is the only way. I'm an obstetrician. All babies should be born in the hospital. And I'm like, wait, look back at, like, my mother is 92. She was born at home. It was a planned home birth. But now we have fire rescue. There was no fire rescue. We have hospitals nearby. She lived out in the boonies. She had a midwife that probably couldn't read. She knew how to do births, but she couldn't read. And there's so much more that we know about labor, delivery, and babies. And so I would re-educate the doctors, you know, from medical school. And I would open up the whole nutrition. You have to take this amount of hours in nutrition so that you can make the woman a team player. And I would go to all the rescue, all the EMT, and re-educate them. You know, because some of them, especially if they come to a home birth, they have an attitude towards us. You know, it's like, that's not your job. Your job is, we called you, we need you. Take the mom or the baby, whoever needs to go in, and, you know, here, we've got charts, we've got this, we've got that. Don't project your upset onto us. We need you to take care of, do your job. And so you have to educate. It would be to educate. And then I've even gone to elementary schools. I've had teachers that have asked me to come in and talk to them about what's a midwife. And of course, I have to be careful, you know, anatomically and, you know, what I'm saying. But the kids are sitting there and their eyes are like, you know, they can't believe it, you know, and they're like, wow, this is so cool. And then also the nursing schools. So education from the ground up.
Thank you so much.
Mm-hmm.
Thank you.